The role of emotion and motivation in panic disorder. Emotions and motivation are intertwined to form a multifaceted sequence of reactions to a stimulus. Let's say you are out on an extremely hot day. In this case, the stimulus is heat produced by the sun. You will experience some physiological symptoms and some emotional symptoms. You'll probably be sweaty and thirsty. You may feel frustrated and angry, and you will be motivated to get out of the heat, find some shade, feel cool, and probably drink a tall glass of something cold. But what if the stimulus is fearful or life-threatening? What if, for example, you heard a sudden bang, or you were in the path of a moving vehicle, or worse yet, you've been chased by a hungry predator? Sheridan Kavanaugh on Harvard Health Publishing explained how your mind and body coordinate beautifully to produce a normal response to danger or threat. The amygdala signals the hypothalamus, the command center that controls the autonomic nervous system. ANS has two sides that control autonomic functions: the sympathetic and parasympathetic nervous systems. The sympathetic nervous system is like the gas pedal of a car, causing acceleration of functions, while the parasympathetic functions like the brake to slow the body down, but both must work together to prepare the body for flight, fight, or freeze. Okay, so back to you being chased by a hungry predator. The amygdala, as the emotional processing hub, has signaled the hypothalamus. The hypothalamus activates sympathetic nervous system. It signals the adrenal glands, and these glands begin to release the hormone epinephrine or adrenaline and norepinephrine into the bloodstream, which causes increased heart rate and blood pressure, increased breathing rate, sharper eyesight, alertness, hearing, and other senses. Epinephrine also causes the release of fats and increased blood sugar for energy to all muscles. Digestive functions are inhibited. This all happens extremely fast before the individual can appreciate the circumstances. That's why a person can jump out of the path of a speeding car before fully processing what he's doing. As the initial epinephrine surge subsides, if the situation still poses as stressful or threatening, the hypothalamus activates the secondary stress response system, the hypothalamus, pituitary gland, and adrenal glands, the HPA axis, and releases corticotrophin releasing hormone, which travels to the pituitary glands and trigger the release of endocorticotropic hormone. This hormone triggers the release of cortisol from the adrenal glands to keep the body in a heightened state of alertness until the threat passes. Let's see how these emotional and physiological responses to a threat relate to panic disorder. According to the American Psychiatric Association APA 2022, panic disorder is marked by recurrent unexpected panic attacks, and a panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes. This intense abrupt surge can occur when someone is already anxious or the person could be completely calm. The term unexpected refers to a panic attack for which there is no obvious cue or trigger at the time of occurrence. That is, the attack appears to occur from out of the blue, such as when the individual is relaxing or emerging from sleep. In contrast, expected panic attacks are those for which there is an obvious cue or trigger, such as situations in which panic attacks have typically occurred. During the panic attack, at least 4 of the following symptoms are experienced by the individual: palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, feelings of choking, chest pain or discomfort. Nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensation, paresthesias, that's numbness or tingling sensations. Derealization, feelings of unreality or depersonalization, being detached from one's self, fear of losing control, going crazy, and fear of dying. To meet the criteria for a disorder, at least one of the attacks would be followed by 1 month or more of persistent worry about having other panic attacks, or what can happen because of it, or significant maladaptive behaviors geared at avoiding having a panic attack. Also, the symptoms should not be attributable to the effects of a substance or another disorder. What makes panic disorder different from other anxiety disorders is the intense physiological symptoms that accompany it. People feel like they're having a heart attack, having a stroke, or going crazy. Therefore, the object of danger is specific in terms of the body's response. School of Life described the real life story of Zach. Out of the blue, in his 20th year, Zach began to develop panic attacks at the most inconvenient of moments. An office presentation or business networking event, he'd feel extraordinarily anxious, get an urge to run away, and often need to find a bathroom very fast. It was becoming hugely debilitating for Zach, who worked in a rather unforgiving, fast moving tech company in San Francisco. A friend recommended a therapist. First thing the therapist told him was that here in this room, he could panic just about as much as he liked, and it wasn't going to be a problem. He could run away, faint, be sick, all was fine by her. That helped immensely. They began talking about what some of these panic attacks might have in common. It was actually deeply refreshing to talk to someone who just kept the focus on what he was feeling and tried to decode it for him. Something struck Zach as he spoke. The panic he felt had a habit of arising whenever there were expectations on him. Whenever people were waiting for him to be impressive, clever, or decisive in some way, and there was a chance to make himself look like a fool or a jerk. It was as though one part of him was deliberately undermining and sabotaging the other. Whenever there was opportunity to shine or triumph, if it carries on like this, I'll have no option but to head back home and live with my parents, remarked Zach darkly one day towards the end of the session. That turned out to be the start of a very fruitful line of discussion. Zach had grown up in rural Minnesota. His father was a roofer. Neither of his parents had been to college. The gap between Zach and his parents was now huge. He might earn in 1 year what his father earned in 5. The more Zach told the therapist about his background, the more he realized what a burden of guilt he was carrying around with him. The guilt that success was leading him to succeed his parents in a way that was at once exciting and properly frightening. Zach wanted success, but being successful was also threatening to separate him from the two people who he felt the greatest debt to. The panic attack seems like a devilish way to stay faithful to his parents. It was like an act of self-sabotage calculated to protect his parents. And especially the father, who had some competitive and envious sides to his otherwise warm nature. All this from the risks of humiliation. It was as though in one part of his mind, Zach didn't believe that he could be both an impressive adult and a loyal son. Discovering this about himself helped Zach a lot. Gradually, the symptoms lessened. He learned how to understand himself for not wanting to have the life that his parents had had and to forgive himself for looking for something better. At the same time, he accepted that he could remain loving and admiring of many qualities his parents had. Zach continued in therapy for a year. The attack stopped completely without any need for medication. It was as if part of his mind had been listened to and no longer felt the need to ruin Zach's life in order to be heard. Recently, Zach was invited to address a conference of 2,000 delegates. The speech went perfectly. The symptoms experienced in panic attacks are directly linked to the physiological processes involved in a stress response. In panic disorder, people are physiologically responding to an unseen or unconscious threat. So where is this threat coming from? There is no single etiological pathway to panic disorder. Several factors such as genetic, neurobiological, environmental, and temperamental factors may contribute. People can be genetically predisposed to panic disorder. These predispositions act as a catalyst for the development of disorders. For example, a child of a person with panic disorder or other anxiety or depressive disorders is more likely to develop the disorder. Panic disorder has a heritability rate of 48%. Jennings and Koenigsberg observed that poorly regulated and maladaptive neural security and dysfunctional fear processing in the amygdala and other brain regions, like the prefrontal cortex and hippocampus, have been implicated in the development of anxiety disorders. Greater activation in the amygdala and weaker prefrontal cortex activity have been observed in individuals with panic disorder. Furthermore, subregional shape alterations have been observed in the amygdala of patients with panic disorder, leading to hyperactivity. Poor regulation of neurotransmitters gamma aminobutyric acid or GABA, serotonin in the amygdala, and norepinephrine in the locus coeruleus have also been implicated in panic. GABA is the primary inhibitory neurotransmitter for the central nervous system. It functions to reduce neuronal excitability by inhibiting nerve transmission, blocking certain brain signals, and decreasing activity in your nervous system. It's thought to play a major role in controlling nerve cell hyperactivity associated with anxiety, stress, and fear. The family environment is the main environmental contributor to emotional disorders and has a significant impact on the development of panic disorder. Children who are abused or neglected are more likely to develop fear-related disorders, and children with separation anxiety are more likely to develop panic disorder. Experiencing uncontrollable stresses and interpersonal trauma such as abuse, rejection, and loss can lead to anxiety later. Other influences during childhood and adolescence may include negative parental behaviors such as being overly controlling, demanding, protective, or rejecting. Furthermore, insecure attachments, example an anxious, fearful attachment, with parents and caregivers are correlated with anxiety disorders. Anxiety denotes an unconscious fear of injury to an already wounded self, protected by maladaptive defenses like avoidance. Individual temperament has been shown to account for anxiety disorders like panic. Persons with panic disorder tend to ruminate, repetitive thinking of negative feelings, events, and consequences, and be passive by not actively trying to solve a problem. Some individuals are prone to experiencing negative emotions and are highly sensitive to anxiety. Battaglia 2013 noted that the gene-environment connection has been of great interest in understanding panic disorder. In addition to genetic predispositions that may exist, anxiety seems to be the main adaptive response to environmental stress. Typically in PD, panic attacks initially occur unexpectedly. After several attacks, etiological conclusions are falsely drawn between ecological conditions, example, being in a crowded room, and panic attacks, and people start avoiding the places of potential attacks, leading to dysfunction in different areas of life, and the development of PD with agoraphobia, fear of places and certain situations. Epigenetics is an area of study on how environmental conditions change gene expression and what is the environmental effects on genes. Events in childhood and adolescence can cause heightened susceptibility to events that alter chemoreception, how we respond to chemical stimulus. Furthermore, verbal reinforcement on how to act in a crisis is less effective than modeling the behavior. If children see anxious or fearful responses to threat or stress, that is the model they would imitate. Research among toddlers shows that overreaction by a parent to a minor event, even when nothing happened, caused significant distress to the toddler. No one factor is implicated, and panic disorder can be initiated from any factor in any order. Sometimes there exists a genetic vulnerability based on a neurobiological defect acted upon by environmental factors. Also, it appears that one's environment can shape temperament, which can produce neurobiological defects. Temperament can be acted upon by environmental factors. After all, research shows neurobiological defects can be corrected by CBT without medications. Furthermore, the environment can change gene expression. This is a multifaceted phenomenon, and the best defense is to protect the most vulnerable, children and adolescents, from abuse, neglect, control, rejection, and unhealthy negative family environments. Create a space for them to thrive emotionally and model to them how to respond in threatening or stressful situations. According to APA, in the general population, 80% of individuals with panic disorder had a lifetime comorbid mental diagnosis. The prevalence of panic disorder is elevated in individuals with other disorders, particularly other anxiety disorders, and especially agoraphobia, major depressive disorder, bipolar 1, bipolar 2 disorder, and possibly mild alcohol use disorder. While panic disorder occasionally has an earlier age at onset than the comorbid disorders, onset often occurs after the comorbid disorder. It may be seen as a severity marker of comorbid illness. Panic disorder is significantly comorbid with numerous general medical symptoms, conditions including dizziness, cardiac arrhythmias, asthma, COPD, irritable bowel syndrome, However, the nature of the association between panic disorder and these conditions remain unclear. Panic disorder can manifest differently across cultures. According to APA, culture-specific symptoms, example, tinnitus, neck soreness, headache, uncontrollable screaming or crying may be seen, but such symptoms should not account as one of the 4 required symptoms of diagnosis. Various other cultural concepts of distress are associated with panic disorder, including ataque de nervios, or attack of nerves, among Latin Americans, and Kyal attacks and soul loss among Cambodians. Asians experience high rates of dizziness during panic attacks, while African Americans experience paresthesia, tingling and numbness, like pins and needles. There are evidence-based treatments available for panic disorder, including cognitive behavioral therapy, psychodynamic therapies, emotionally focused therapy, experimental therapies, and medications. Cognitive behavioral therapy is built on the premise that you change your thoughts, you change behavior. CBT targets cognitive biases, allowing an individual to consider alternative reasons for negative events. CBT has been shown to correct cortical abnormalities associated with panic and decrease activity in the hippocampus and other brain regions. Even brain images of individuals with anxiety-related disorders show changes in their brain structure after receiving CBT. Psychodynamic therapies, first developed by Sigmund Freud, focus on patients working through unconscious conflicts. In the story of Zach that we discussed earlier, the therapist was able to help Zach understand the unconscious issues and conflicts that threatened his mental health and initiated his panic attacks. In Zach's case, his loyalty to his family undermined his prospects of success. Emotionally focused therapy was developed by Johnson, based on attachment theory. The theory posits that broken or insecure connections resulting from rejection, fear, anxiety, and uncertainty with significant actors such as parents could lead to psychological distress. The maladjustment and insecure attachment increases one's vulnerability to mental illness. EFT assesses the individual within the framework of those relationships to heal what was broken. Quentisberg recommends emotionally focused psychodynamic therapy to help patients process their conflict-laden conscious and unconscious emotions. Experimental or exposure therapies can focus on the individual learning key areas of the body or presenting images related to self-wounds and past experiences. 2 types of medications have been used to treat panic disorder: antidepressants and benzodiazepines. Antidepressants can be used to correct norepinephrine and serotonin imbalances. Serotonin and norepinephrine reuptake inhibitors are preferred for PD treatment. SNRIs increase level of serotonin and norepinephrine in the brain by blocking or delaying their reuptake by nerves. Cymbalta or Lexatine and Pristiq or desflexelvine are examples. It is recommended that they be coupled with benzodiazepines. Benzodiazepines are a class of medications that slow down the activity in your brain and nervous system. They are most often used for treating anxiety and related mental health conditions, as well as brain-related conditions like seizures. Ofrasulon or Xanax and Klonopin are examples. Physiological symptoms of panic disorder are a collective response to an unconscious threat, similar to what is experienced in a normal stress response. There is no single etiological pathway to panic disorder, as genetic, neurobiological, environmental, and temperamental factors may all contribute, and these factors can interact in a myriad of ways. Panic disorder is highly comorbid with other mental and physical conditions. Zach's story by School of Life 2016 reinforces the effectiveness of psychotherapy in uncovering unconscious self-sabotaging desires and treating panic disorder. An integrative approach, however, combining psychotherapy and medications based on clients' needs is the best approach for treatment.